Hi everyone. Welcome to you all again to this pediatric university exam question answer discussion. So, in this video, we are going to discuss about the common infections in the children. First, we have to learn about the malaria. That is a most common parasitic infection that is happen in the case of children. So, about the malaria, it is an acute infectious disease that is caused in humans by 5 species of the plasmodium, and that is transmitted by the vector, that is Anopheles mosquito. So this is the malarial, the different 5 malarial parasites of the man, that is Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, Plasmodium malariae, and Plasmodium knowlesi. So these are the 5 malarial parasites which infected the man, and it is spreads by the bite of the female Anopheles mosquito, that is a vector. Then some data about the life cycle of the Plasmodium. So, about the life cycle in the man, the parasite residing in the liver cell and RBC, which reproduces by asexual method, schizogony, and man is the intermediate host of the malaria. Then, in female Anopheles mosquito, the male and female gametocytes divides by sexual method. Hence, it is a definitive host. So, definitive host for the malarial disease is female Anopheles mosquito, and the intermediate host is the man. That is always asked as an one mark question. Intermediate host for the malaria is man, and the definitive host is the female Anopheles mosquito, which reproduced by sexual method. But the man, that is intermediate host, which is reproduced by asexual method. And the various stages in the Plasmodium vivax as well as the Plasmodium falciparum are trophozoites, ringworm, schizont, and merozoite. So this is the diagram which showing the life cycle of the malarial parasite. That is an infected female Anopheles mosquito which bites to an human. The sporozoites from the salivary gland of the Anopheles mosquito released into the bloodstream of the human, and it enters into the hepatic cell, and some of the form of the sporozoites which are enters into hepatic dormancy as hypnozoites, which later release to produce the relapse of the symptoms. But now in the cycle hepatic cell, there will be sporozoites in the hepatic cell, and the mature liver cell schizont will be produced, and it will rupture and releases the merozoites into the circulation. And these merozoites enter into the erythrocyte, and in the erythrocyte, trypnozoites are produced. And finally, there will be erythrocyte schizont is produced, and because of this, there will be the rupture of the erythrocyte happens, and the schizonts which are released into the circulation, and the circulation which releases the gametocytes into the blood circulation. And again, a Anopheles mosquito, normal Anopheles mosquito, which bites and infected human beings, the gametocytes which uh, enters as meals, blood meals into the normal Anopheles mosquito. And in the so this all about the uh, happens in the human body, that is the intermediate host. And rest of the cell life cycle of the malarial parasite which happens in the female Anopheles mosquito's body, that is these gametocytes, that is microgamete and macrogamete, fused to form the zygote. And in these zygote which enters with the mosquitoes midgut, and which causes the formation of the oocyst. And this oocyst burst out and produces sporozoites, which is stored in the salivary gland of the female Anopheles mosquito, which again binds to a normal a human, and which causes the infection in the human being. So these are all about the uh, life cycle of the malarial parasites, that is both in the man, that is in a sexual cycle, and also in the female Anopheles mosquito as the sexual cycle. So that's all about the life cycle. And this relapsing form, that is the hypnozoid hepatic dormancy, which will later produces relapsing symptoms. Then about the clinical features, no age is exempt. The presentations of malaria which may differs in different age groups, smaller children which may have the atypical presentations. Then In uncomplicated malaria, the fever that is either quotidian or tertian frequency, not common in the children. Usually, it is high-grade fever, typical cold stage rigors, then followed by the hot stage, the sweating stage which may not be present. The child is playful in between the fever spikes. Everything that shivers is not malaria. Anemia and also in uncomplicated malaria there will be anemia and splenomegaly will be there. And in the neonatal age group, neonatal malaria, maternal malaria is an important cause of the abortion, stillbirths, and low birth weight. Neonatal malaria is uncommon because passively transferred maternal antibodies, fetal hemoglobin retards plasmodia growth, explosive breast milk lacks PABA required for the parasite, para-amino benzoic acid required for the parasitic growth. Because of that, the neonatal malaria is uncommon. And disease manifests around 2 to 8 weeks with the fever, jaundice, hemolytic anemia, thrombocytopenia, and hepatosplenomegaly. So, in malaria in the infancy and the early childhood, it is most susceptible and may get complicated in the early childhood and infancy. The classical paroxysm is exception rather than rule. Child which appears listless, irritable, or drowsy, vomiting with a fever 105 to 106 degree Fahrenheit, fever which subsides itself or with the medication which may recur at a regular interval, and febrile seizure which can occur. Respiratory symptoms most common is fever, cough, wheezing, and crepitations. Gastrointestinal symptoms also occurs in the case of the presentation of the malaria, marked vomiting and loose stools, and urticaria which may occur. Then WHO clinical diagnosis of malaria. In the low risk areas, the history of exposure to malaria, there is history of the fever for last 3 days and no features of other severe disease. These are the diagnostic criteria in the low risk areas. In the high risk areas, history of the fever in the last 1 day. In the children, history of the Palmer panel, that is hemoglobin less than 8 gram percentage in the high risk area is the criteria for the clinical diagnosis for the malaria in the according to WHO. Then what is complicated malaria? It is also act as a also asked as a short note that is complicated malaria. The falciparum infection which are more prone to complications because the most commonly the young and old RBCs which are attacked in the case of Plasmodium falciparum infection, the schizogony which occurs in capillaries of the internal organs, the multiple infections of RBC that is more than one parasite attacking single RBC. Because of these reasons, falciparum infections which are more prone to complications. And then, what are the criteria for the complicated malaria? Uh, Defined as asexual parasitemia with the presence of one or more of the following features in the absence of an alternative cause. So these are the features which is indicative of the complicated malaria, that is impaired consciousness, that is definite GCSE, that is Glasgow Coma Scale less than 11 or Blantyre less than 3 in the children, and prostration, generalized weakness, cannot sit without help is there, and multiple convulsions, more than 2 episodes in 24 hours will be present, and if there is any shock, that is impaired perfusion, hypotension less than 70 millimeters of mercury, then pulmonary edema, that is chest X-ray and SpO2 less than 92% on the room air, and the respiratory rate is greater than 30 per minute. So that is indicative of the pulmonary edema, that is a feature of the complicated malaria. Then significant bleeding, that is recurrent or the prolonged bleeding. Severe malarial anemia, that is hemoglobin less than 5 gram per deciliter to the children and less than 12 years. And the hemoglobin less than 7 gram per deciliter in the adults with the parasite count greater than 10,000 per microliter. And the presence of jaundice also a criteria for the complicated malaria, that is jaundice, which means serum bilirubin greater than 3 milligram per deciliter with the parasite count greater than 10,000 per microliter. And also if there is an renal impairment, there is plasma creatinine greater than 3 milligram per deciliter, the urea greater than 20 millimole per liter. Then, if there is any presence of acidosis, that is a base deficit of the greater than 8 milliequivalent per liter, or plasma bicarbonate less than 50 millimole per liter with rapid and deep breathing. Hypoglycemia, that is glucose less than 40 milligram per deciliter. Hyperparasitemia, that is Plasmodium falciparum parasitemia greater than 10%. So these are the features which is suggestive of the complicated malaria. Then about the cerebral malaria, it is the manifestation of the complicated Plasmodium falciparum malaria. Definition for cerebral malaria, which include deep coma that is persisting for the 30 minutes, following generalized convulsions. and is confirmation by the finding asexual forms of Plasmodium falciparum on the peripheral smear or bone marrow examination. Other causes of the encephalopathies which are ruled out before confirming the cerebral malaria. In fetal cases, histopathology of the brain which confirms the diagnosis of the cerebral malaria. Treatment is same as with the complicated malaria along with symptomatic and supportive treatment for the raised intracranial tension and the seizures. Then how will you diagnose the malaria? Usually, parasitological diagnosis, which includes light microscopy and rapid diagnostic test. Light microscopy remains the gold standard for the detecting and identifying the malarial parasite. For the light microscopy, we have to collect the blood sample. The blood collected as soon as malaria is suspected, irrespective of the fever spike, but before anti-malarials. Before anti-malarials, we have to collect the blood and collect it from the fingertip or the earlobe. This because capillary-rich areas have the greater parasite intensity. So the fingertip and earlobe which have the greater capillary-rich areas. And blood from the venopuncture collected in the EDTA vials and films prepared within 2 hours. So these are the things we have to keep in mind for collection of the blood samples for the preparing the light smear for the light microscopy. Then stain with the field stain or the James stain and examination both thick and thin films which have to be prepared soon after collection to minimize distortion of the parasites and RBC. Minimum 100 fields to be examined. If negative, examine for 3 days if clinical suspicion is there. And thick film is 10 times more sensitive than thin for diagnosis due to large amount of the blood. In thin film, as fixed monolayer of the RBC is available, morphological identification of the parasite to species level and stage of parasite which can be determined by using the thin film. And thick film is for the detection of the amount of parasites, but thin film is for the detection of the species level identification. Then what are the advantages of the microscopy? The skilled microscopist with the proper infrastructure, there is 5 to 10 parasites per high power field is picked. And the species identification which can be done using the thin film and stage of parasite using the thin film and parasite density for monitoring severity, evolution and therapeutic efficacy can be determined by using the light microscopy. What are the disadvantages? It is a time consuming, often requiring greater than 60 minutes from the blood collection to result, and labor intensive, needs significant technical skill and proper infrastructure, cannot detect parasites sequestrated deep in the vascular compartment. So these are the disadvantages. Then about the so first one diagnosed test is the light microscopy. Second is a rapid diagnostic test. It is developed with the hope of cheap, rapid, and accurate diagnosis of malaria, sensitive at a parasite level 100 to 500 per microliter. The principle is monoclonal antibodies targeted against the parasite antigen. A test kit has specific antibody labeled with a visually detected marker. If antigen is present, antigen antibody complex is formed and it is assessed against the control. Like our urine pregnancy test, we have to detect the presence of malarial parasites using rapid diagnostic test. What are the advantage of the rapid diagnostic test? It is relatively easy with the minimal training, does not need electricity and results are available rapidly, able to detect falciparum infection even when the parasites are sequestrated in the deep vascular compartment and thus undetectable by the microscopy. What are the disadvantages of the rapid diagnostic test? Kit which may not be stable under field conditions in tropics. Qualitative, it is not quantitative, not suitable for the prognostication and finding out treatment response. Decreased sensitivity at lower levels of parasitemia, false positive with gametocytes, cannot determine the stage of parasite. That is, in the early ring form of the late Schison, we cannot determine the stage of parasite using the rapid diagnostic test. Then, how will you treat a case of malaria? Children can tolerate oral drugs better and symptoms resolve more quickly. The full treatment to be given, resistance suspected if patients does not respond parasitologically in 72 hours. So that is, if there is no response within 72 hours of the administration of the oral drugs, the resistance is suspected. Then about the treatment of the uncomplicated Plasmodium vivax malaria, the chloroquine 10 milligram per kilogram followed by 10 milligram kilogram at 24 hours and 5 milligram kilogram at 48 hours. That is total of 25 milligram per kilogram should be administered. Tablet 150 milligram base syrup 5 ml 50 ml is equal to 50 milligram. So chloroquine 10 milligram kilogram followed by 10 milligram kilogram at 24 hours and 5 milligram kilogram at 48 hours should be administered. And along with that, primaquine, that is 0.25 milligram per kilogram once daily for the 40 days to prevent the relapses starting on the day one, should be administered along with the chloroquine. And the primaquine is given to prevent the relapse which occurs because of the hypnozoites in the liver in case of Plasmodium vivax and Plasmodium falciparum does not have the persistent liver forms. That is, hypnosis is the characteristic finding in case of the Plasmodium vivax. So we have to give the primaquine in the case of Plasmodium vivax infection, but in the case of Plasmodium falciparum, which does not have the persistent liver forms, we do not have to give the primaquine. And the GC-spirit testing is to be done if possible in the Plasmodium vivax. In GC-spirit deficient individuals, primaquine 0.75 milligram per kilogram once a week for 8 weeks should be given. Avoid primaquine in infants. This complete treatment of the Plasmodium vivax is called the radical treatment. Then about the treatment in the chloroquine-resistant vivax that is not responding to the oral drugs within 72 hours of the Plasmodium vivax, we have to give the sulfadoxine pyrimethamine resistance uh, more rapidly in the plasmod. That is the sulfadoxine pyrimethamine resistant, which is more rapidly in the Plasmodium vivax that is compared to the Plasmodium falciparum. Hence, artemisinin combination therapies with the piperacin, mefloquine, or the lumefantrine recommended in the case of chloroquine resistant vivax. The mixed malaria treated with the also treated with the artemisinin combination therapy. Then about the treatment of the uncomplicated Plasmodium falciparum malaria. In view of gradually increasing resistance, all cases of the Plasmodium falciparum is to be treated with the artemisinin combination therapy in both public and private systems. Artemisinin combination therapy is rapid clear that will result in rapid clearance of the parasites, no resistance is known, and almost no side effects will be there. That is artesunate 4 milligram per kilogram orally for 3 days with the sulfadoxine 25 milligram per kilogram and pyrimethamine 1.25 milligram per kilogram on day 1 single dose, or any artesunate plus mefloquine 25 milligram per kilogram of base splits into 50 milligram per kilogram on day 2 and 10 milligram per kilogram on day 3. Then another option is artemether plus lumefantrine orally twice daily for 3 days. In 5 to 14 kilogram, one tablet twice daily. In 50, 24 kilogram, the 2 tablets twice daily. Greater than 25 kilogram, 3 tablets twice daily, or 1.7 milligram per kilogram, or dose of artemether twice daily for 3 days. And these are the treatment options for the treatment of the uncomplicated Plasmodium falciparum malaria. For the reducing transmission, a single dose of primaquine 0.25 milligram per kilogram given for gametocidal action. GC spirit testing is not required with the new low dose. Not in pregnant women, infants less than 6 months, and women breastfeeding infants less than 6 months. Then treatment of the complicated Plasmodium falciparum malaria. Treat adults and children with a severe malaria with the intravenous or intramuscular artesunate for at least 24 hours. Once patient has received at least 24 hours of oral therapy, complete treatment with the 3 days of artemisinin combination therapy. Children weighing less than 20 kilograms should be given 3 milligram per kilogram per dose artesunate. Larger children and adults, we have to give 2.4 milligram per kilogram dose at 0, 12 and 24 hours, followed by 1.2 milligram per kilogram per day for 3 days. Daily dose which can be shifted to the oral when possible. And also primaquine 0.25 milligram per kilogram single dose to prevent the transmission is administered. Complicated Plasmodium vivax to be treated in the same way except primaquine for the 14 days. Then what are the parenteral alternatives to artesunate? Artemether 3.2 milligram per kilogram intramuscularly, maintenance 1.6 milligram per kilogram intramuscularly daily for 6 days or shift to oral whenever possible. And also we have to give the alternative as quinine, 20 milligram quinine salt per kilogram on admission, that is IV infusion in 5% dextrose, dextrose saline over a period of 4 hours, followed by maintenance dose of 10 milligram per kilogram 8 hourly. Infusion rate should not be exceed 5 milligram per kilogram per hour. Along with quinine, we have to give doxycycline or clindamycin to be used for 7 days. Patients receiving artemisinin derivatives should get full course of oral ACT. However, artemisinin complex therapy containing mefloquine should be avoided in the cerebral malaria due to the neuropsychiatric complications. In the case of recurrent falciparum malaria, recurrence which may result from reinfection or recrudescence, that is treatment failure which may be due to the resistance, suboptimal dosing, poor adherence to the treatment, vomiting, and unusual pharmacokinetics in individuals or substandard medicines. It should be confirmed by the microscopy. Then what are the supportive treatment for the malaria? The good nursing care, nasogastric tube insertion in the comatose child, oxygen supplementation, restore the circulatory volume by the IV or cannulas, IV antibiotics if sepsis is suspected, lorazepam for the convulsions, and avoid steroids and mannitol. In the case of severe anemia, we have to give the packed cell volume if hemoglobin is less than 4 gram per deciliter or with acidosis. Congestive cardiac heart failure and hyperparasitic, we have to give the packed cell volume. In the case of lactic acidosis, correct hypovolemia and treat anemia. Correct hypoglycemia, treat the acute kidney injury. In case of hyperpyrexia, that is absolute temperature greater than 39.5 degrees Celsius, the treatment is monitor rectal temperature frequently, remove excess clothing, tepid sponging plus fanning should be required. The paracetamol or the suppository should be administered. If there is any circulatory collapse, that is also known as algid malaria. That is, it is defined as the systolic blood pressure less than 50 millimeters of mercury in the less than 5-year-old child associated with the gram-negative septicemia or marked gastrointestinal bleeding. The treatment which of the circulatory collapse of algid malaria, which consists of normal saline with the fresh blood, and also broad-spectrum antibiotic should be given. Then how will you prevent the malaria? Malaria elimination by 2020 launched in 2017. National Malaria Day is 25 April. By the vector control, we can prevent the, that is mostly it is transmitted by the female Anopheles mosquito. Therefore, by vector control, we can prevent the malaria. So by the anti-adult measure, that is insecticide spray with the malathion and phenitrathione due to the vector resistance to DDT. And also space application, that is pesticides in the form of fog or mist, individual protection by the use of repellents and bed nets, etc. We have to control the vector. And anti-larval measures like larvicides, that is Stemophos, Gambusia fish, and Paris green should be given. The source reduction, reduce mosquito breeding sites as possible. Then water level management, that's most cost effective, is changing water salinity or allowing organic matter growth. Then personal protection by the pyrethroid impregnated bed nets, washable wire mesh screens, ethyl toluamide are used for the personal protection. So these are for the vector control, anti-adult measures, anti-larval measures, personal protection, and water level management by the, and also by the reduce the mosquito breeding sites. So these are the vector control, and there will be chemoprophylaxis for the malaria. Indication for the chemoprophylaxis for the prevention of malaria is chemoprophylaxis is recommended for the travelers, migrant laborers, and military personnel exposed to malaria in the highly endemic areas. For short-term prophylaxis, that is less than 6 weeks, we have to give the doxycycline 100 milligram daily in the adults and 1.5 milligram per kilogram for children more than 8 years old. The drug should be started 2 days before travel and continued for the 4 weeks after leaving the malarial area for the short-term chemoprophylaxis. And for the long-term chemoprophylaxis, that is more than 6 weeks, we have to give the mefloquine 5 milligram per kilogram up to 250 milligram weekly and should be administered 2 weeks before, during, and 4 weeks. Sure, we have to administer this mefloquine 2 weeks before and during the stay in the endemic areas, and also the 4 weeks after leaving this endemic area. The mefloquine is contraindicated in the case with the history of the convulsions, neuropsychiatric problems, and cardiac conditions. The chloroquine 5 milligram per kilogram weekly, which may be used in sensitive areas or in the pregnant woman. So this is about the chemoprophylaxis in the malaria to prevent the malaria when any travelers or migrant laborers or the military personnel which are exposed to malaria malaria in the highly endemic area. So by the vector control and certain chemoprophylaxis of the malaria, we can prevent the occurrence of the malaria. Usually, the questions which are usually asked are the first question is 7 years old child which was brought with fever and seizure. On examination, the patient is deeply comatose, pale and significant hepatosplenomegaly. Answer the following. What are the possibilities? What clinical signs will you look for in this case? How will you investigate? How will you manage? So this is a case of cerebral malaria. How will you get that from this question? That is, it is a 7-year-old child, and on examination, there will be fever and seizure, and also there will be deeply comatose. So the multiple convulsions more than 2 episodes in 24 hours with a deep or unreversible coma is a characteristic phase of cerebral malaria, severe malaria. Other clinical findings which include the failure to feed, hepatosplenomegaly, severe normocytic anemia or pallor, deep breathing, shock, clinical jaundice, hemoglobinuria, hypoglycemia, metabolic acidosis, and also point towards the cerebral malaria. That is first question regarding the malaria. I usually asked as a essay question in the university pediatric. Then another question which are usually asked are draw and label life cycle of the plasmodium vivax. Then the treatment of the plasmodium falciparum malaria. Then complicated malaria, falciparum malaria complications. Drug of choice in the treatment of cerebral malaria. Then about the peripheral smear examination malaria, life cycle of malarial parasite. Uh, so these are all about the malaria. Thank you.